Hi, good night, everybody. My name is Jesse Jones Armour, and I am one of the DM urology students. So tonight we're going to be going through genitourinary pathology. Um, so a few topics that we're going to go through tonight is a little bit extensive, but we're doing testicular tumors, prostate adenocarcinoma, renal carcinoma, as well as urothelial carcinomas. So starting from bottom to top, um, neoplasms occur in about 6 in 100,000 men and peak between the ages of 15 to 35. The majority of them are germ cell tumors at 95%, and these could be categorized between seminomas and non-seminomas. And the remaining 5% of sex are called sex cord tumors. Now, to understand this, it helps to know a little bit of anatomy. So here on the far left, we have testes, right? So um, if you go in, you will see that you have your tunica albuginea, and then you have your seminiferous tubules separated into lobules by various septae. Um, Let me just see if you can see my pointer. It's okay. And then you have a cross section of your seminiferous tubule here, where you have inside of your lumen, you would have your sperm being produced. You have your Sertoli cells and your Leydig cells on the outside. And then these cells with the large vacuoles, these would be your germ cells, which will be making up the germ cell um, tumors that we'll be going to just now. And then we have an actual histology slide where you can see it a little bit better what we're talking about, right? So testicular tumors are the most common tumor in men between the ages of 15 to 35, and it accounts for about 10% of the total cancer deaths in that group. Now, there are several risk factors for testicular tumors, such as cryptorchidism, which is the most common one, which is undescended testes. You have Klinefelter syndrome. And of note, there is a strong family history where it is up to 4 times in a father to son versus is up to 8 to 10 times between brothers. And then it's 5 times more common in Caucasians than African Americans or Africans. It is associated as well with tyrosine kinase KIT and BAC. And as we mentioned before, it is classified between seminomas with as well as non-seminomas, which would be the yolk sac tumors, choriocarcinomas, and teratomas. So continuing with that, most of the tumors are mixed, up to 60% of them. Um, the most common finding of testicular tumors are hard, painless, irregular testes. Sometimes you may have gynecomastia or precocious puberty, especially in the Leydig and choriocarcinomas. There are different investigations that we do for this. Of note, we do not do biopsies because if you remember from your embryology, the testes descend from the abdomen and have a different lymphatic drainage than the scrotum. So if you were to use a needle to take a biopsy, then you'd actually be seeding the scrotum and you'd have to do an excisional biopsy of the scrotum as well. Therefore, the first line investigation after you found your hard testes, you'd want to do a scrotal ultrasound and you want to do biomarkers such as the beta HCG, AFP, which is alpha fetoprotein, and lactate dehydrogenase, the LDH. Then you would do the actual diagnosis would be with a radical orchiectomy, which is an inguinal orchiectomy that is done. You also would consider doing a CT chest, abdomen, pelvis with IV contrast if you are considering metastatic spread. And you'd want to do involve brain as well for if you can if you're considering that is metastatic spread. As we mentioned before, the three main biomarkers would be the HCG, the AFP, and the LDH. And management of such would be radical orchiectomy. You have your retroperitoneal lymph node dissection and radiotherapy of those the seminomas, which will go through a very radiosensitive and chemotherapy for the more aggressive tumors. So the majority, all actually, of the testicular tumors primarily spread through the lymphatics. the first loads that they would go to are the retroperitoneal para-aortic nodes, and then followed by the mediastinal supraclavicular loads. However, they do also have hematogenous spread, especially with the non-seminomas. Then they tend to spread a little bit earlier and more aggressively to the lungs, liver, brain, and bones in that order. Um, then as we mentioned before, the seminomas spread slowly. Majority of them, up to 75%, you would have caught before they actually have any mets, any lymphatic spread. Versus the non-seminoma germ cell tumors, because they metastasize so much earlier, up to 60% of them on diagnosis have already had lymph node spread or sometimes even spread to the lungs. And they do spread via the hematogenous routes more frequently, especially choriocarcinomas, which we'll come to just now. Now, it's usually staged with three main stages, in which you have the tumor stage 1, the tumor classified to confined, to the testes, epididymis, and spermatic cord. Stage 2 have distant spread to retroperitoneal nodes below the diaphragm. And then stage 3 mets outside of the retroperitoneal nodes or above the diaphragm. Now, going into the first one that we're going into in depth, you have your seminomas, which is the most common tumor, germ cell tumor by far, up to 50% of testicular tumors. They do peak in the third decade of life and are associated with KIT activating mutations, as well as PLAB. Now, PLAB, sorry. Clinically, they are large testicular mass, which remain localized. They do have mostly lymphatic spread, but do later go on to hematogenous. And sometimes you would have elevated beta HCG. Grossly, you have a large white or gray mass, usually devoid of any hemorrhagic cysts or necrosis. It usually does not penetrate the tunica albuginea. And on histology, you have sheets of uniform cells, lobules containing lymphocytic infiltrates and large nuclei with few mitotic activity. So the top image, you have your gross depiction, and then you have it on your low power and high power fields here. The second form of tumor would be the embryonal carcinoma, which you peak at 20 to 30 years. It is a lot more aggressive than the seminoma. You have elevated beta HCG as well as LDH, and you have AFP may be elevated in some of the tumors if they are mixed, as a lot of them are mixed. And then you have OCT and PLAP. However, you do not have KIT, unlike the seminomas. Grossly, it is a lot more poorly demarcated, as you can see by the top image. It penetrates the tunica albuginea, and hemorrhage and necrosis is common. It often involves the epididymis as well. On histology, you have sheets of undifferentiated cells. The cells usually grow in alveolar tubular patterns, sometimes with papillary convolutions, and you have large hypochromic nuclei with halos. And we're going on to the yolk sac tumor, other known as the endodermal sinus tumor. These are usually found in children. They have a very good prognosis and may be present in a component of embryonal carcinomas in adults as well. Of note, they have an elevated AFP, so they are generally, if you have a very high AFP, it's more likely pointing towards a yolk sac tumor compared to the others. Grossly, it's non-encapsulated. It is also homogeneous and white, however, just like the seminomas. However, it's more of a mucinous appearance and not as well demarcated. Histology, you have these endodermal sinuses or the Schiller-Duval bodies, where you see in the lower image, you have essentially your body with your mitotic cells around and then surrounding a vascular area, right? So you have a lace-like reticular network of medium-sized cuboidal or flattened cells in these patients. And then you have your most malignant and your rarest of the germ cell tumors, your choriocarcinoma. Of note, this one has a very elevated beta HCG. it is highly malignant, and usually on diagnosis, it has already spread to lungs and liver in several patients. Clinically, there's no testicular enlargement. Sometimes you may just have a small palpable nodule. However, usually it's incidental. Grossly, it's less than 5 centimeters. You do have necrosis and hemorrhage present, as you can see in the top image. And on histology, you have your syncytial trophoblast, which if you see these more regular cells with single nuclei, and you have which these ones actually stain significantly for the beta HCG, and then you have your cytotrophoblasts, which may have multiple nuclei and stretched out elongated cells. Now, the last one of the germ cell tumors is your teratoma. Now, we do know teratomas from other areas as well. They could occur at any age. They're the second most common tumor in childhood. However, they're often mixed with other germ cell tumors. Now, generally, in children, they are all benign. However, if you do have a teratoma in an adult, it's always considered malignant. Now, they could get very large, up 5 to 10 centimeter. They are heterogeneous. Because they are teratoma, they can have any form of cell tissue. So you may find cartilage, teeth, bone, and other tissue involved as well, even brain tissue. So I just have a table here which shows a little bit better on the different type of testicular tumors, as well as their peak incidence. And of note, we have the tumor markers involved. So just so that we remember, seminomas, 10% of them have an elevated beta HCG. Embryonal carcinomas generally don't have anything. The spermatocytic tumor, we didn't cover it here, but it's a subset of a seminoma. You have a yolk sac tumor, up to 90% of them have the elevated AFP. Your choriocarcinoma, 100% of them have elevated beta HCGs. And your teratoma generally do not produce anything. However, they are most often mixed. And if they're mixed with yolk sac, or you may have an AFP, or if they're mixed with choriocarcinoma, you may have elevated beta HCG. And when you do have a mixture in a teratoma, sometimes it picks up the prognosis of the more the lowest prognosis cell type. Now you have your sex cord tumors. They're not as common. They're very rare actually. So you have your Leydig cells. They can occur at any age. They are generally hormonally active. So they do produce androgen, estrogen, and sometimes even corticosteroids. And because of this, you could have presentation with gynecomastia. So if you have a male that has gynecomastia, it is important to check for any testicular mass as well, right? Most of them are benign. On histology, on MacBross, they are homogeneous, golden brown, as you can see in the above images. And microscopically, you will see that they have Renke crystals associated with them. Then you have your Serotoli sex cord tumors, which also present as testicular mass. They are not hormonally active, and most of them are benign, firm gray, white, yellow nodules. You have your gonadoblastomas, which are also very rare. They are a mix of germ cells and gonadostroma. They present in testicular dysgenesis. So almost 100% of patients that have testicular dysgenesis would present with this. You have it's the other way around. All patients who had gonadoblastoma had testicular dysgenesis before. You have germ cell component, can be a seminoma, and then you have the symptoms of seminoma as well in it. You have your testicular lymphomas, which are generally non-Hodgkin lymphomas. They're very common neoplasms in the age above 60. Often they are disseminated at time of diagnosis. And in order of commonness, you have your large B cell, then your Burkitt, then your EBV extranodal carcinomas. Now, I just have some NCCN guidelines just to help summarize the workup and treatment of testicular tumors. So you have a suspicious testicular mass, you do your history and examination, you do your testicular ultrasound, you want to check for your tumor markers, your beta HCG, your alpha fetoprotein, your lactate dehydrogenase, then you would consider doing CT pelvis. You want to do a radical inguinal orchiectomy, because with these patients, the treatments does involve removing one of the testes. And if you do radiation or chemotherapy, you can become sterile. You always want to counsel these patients, especially because they, as we mentioned before, they're usually in their 30s. It's important to talk about sperm banking with these patients. And then when you remove a testes, there's always a possibility that you could put in a testicular prosthesis. And there may be a need to explore this contralateral testes depending on the patient. Pure seminomas, they usually catch them early. So just with a radical orchiectomy, you're fine and you just do surveillance. The non-semi, and if there is spread, they're very radiologic radiotherapy sensitive. So you could go with radiotherapy. Now you have your non-seminomas, then these ones are usually a little bit more aggressive. So sometimes you may want to do more than just surveillance. You may also want to do nerve sparing, retroperitoneal lymph node dissection, or you want to do adjuvant chemotherapy. Yeah. Now going into prostate adenocarcinoma, our second topic, you have the prostate, just a base of anatomy, just so that we understand where we are. The prostate is a roughly 20-gram gland situated at the base of the bladder. It is periurethral, and it is made up of 4 distinct zones, which are also different makeup. So you have your peripheral zone, which is usually where you would have your prostate adenocarcinoma coming from. You have your central zone, you have your transitional zone, which is periurethral, and you're more likely to have symptoms of BPH from that zone. And then you have your fibromuscular stromal zone, or your anterior zone. So this is the most common cancer in men and associated with 10% of cancer deaths worldwide. It is androgen dependent, and risk factors for prostate cancer. You have a family history. That is the most important risk factor. Black males, you have males that are above 50 years, and it could be above 40 years in black males. And then genetically, it is associated with BRCA1 and 2. You have Lynch syndrome as well with the MSH 1 and 2, PMS6, and MHL. And then, of course, you have your Western diet. Now, of note, why it is more common in black males, it's different. There is because we mentioned that the prostate is very androgen dependent, the black males have well, there is an androgen receptor which codes for something called CAG, and different races have different lengths of this protein or this coding that you have, right? And the shorter the coding is the more sensitive to androgens that these patients are. So black males generally have the shortest, with Asian males have the longest, right? And with Western diet, there was actually some studies which showed that Asian males who have the lowest chance of prostate cancer, their risk of prostate cancer actually increased when they would have started a Western diet or would have migrated to the US where the studies were based. However, it does not come up to the same level as the rest of the population there. Presentation of prostate cancer. Now, if you remember where prostate cancer usually forms is in the peripheral zone. Now, as you can see, it's far from the urethra. So usually these patients are asymptomatic. Most of them are actually picked up on screening or with metastatic symptoms. However, if the tumor becomes very large, it could invade into the transitional zone and even block the urethra, which will give you symptoms of lower urinary tract symptoms, right? So you have frequency, urgency, you will have some who's avoiding residual urine, you'll have more frequent UTIs, and of course you'll have AKI, which will eventually develop into a chronic kidney disease. Now, hematuria is also a symptom that they may have. Now, again, because the tumor forms, the adenocarcinoma forms posterior to the urethra, is very rare that hematuria presents. However, if it invades close to the urethra, it could present with hematuria. Now, metastatic symptoms is one of the more common symptoms that patients will actually present with. They usually present with back because the mets usually spread to the pelvis and spine first. You may present with back pain, pelvic pain. You could have even Porter syndrome and lymphedema to the legs. However, lymphedema is very rare, usually more presenting after radical prostatectomy. Yeah. So usually with this, you could do bone scan and it will show you a light up of the the mets in the spine and pelvis. Now, of note, you will have hypercalcemia associated because of the bone mets. However, no, sorry, you do not have hypercalcemia, but you will have an elevated ALP associated. So no hypercalcemia, but an elevated ALP. Now, prostate cancer adenocarcinoma grossly is usually not visible as most are picked up on screening when they're relatively early. However, when they do become large and in advance, you have firm gray-white lesions with irregular margins. Now, the histology really depends on how far along you are. So the the moderately differentiated or well differentiated, these actually form the Gleason system, which we're going to come to just now. So we'll brush over that for now. Diagnosis is usually picked up when screening. So PSA is a non-specific marker, but usually more than 4 nanograms per mil, you would want to screen, you would want to further follow up for biopsy or even an MRI to test for prostate cancer. A more accurate result is PSA density. Because the PSA is so non-specific, you could do a PSA density, which is the PSA over the volume of the prostate, or you could do a PSA velocity, which is the PSA change over time, right? And they have their different ratios, which would give you different thresholds. And this is because so many different things could elevate your PSA level. Prostate diaries, sex, riding a bicycle, all of these ejaculation before, all of these will elevate your PSA. Another one that's common is prostatitis. Could give you a very elevated PSA, and because of this, you could have unwanted prostate biopsies done. You could also screen with DREs. Now, remember I said a lot of the prostate cancer is not, it's very small on presentation, so you may not find it on DRE. And then but if you do find something and then or the PS is elevated, you would do a needle biopsy, which is transrectal or transperineal ultrasound guided core biopsy of the prostate. And then starting recently, they have new advancements, which is the MP or the multiparametric MRI, which gives you the most accurate diagnosis. And it actually guides where specifically you could biopsy for the prostate serum. Now, going back into the Gleason score, prostate cancer, this was initially developed by Donald Gleason in the 1960s. And however, in 2014, the ISA, which is the International Society of Urological Pathologists, further refined this into 5 grade group categories. Now we're going to the Gleason and then we're going to the grade groups first. So you do have patterns 1 and 2, which are very organized glands. You would never really see these on a pathology report because these are considered normal or benign. Then you have 3, which is infiltrating variable size glands. Then you have 4, which is fused cribriform glands, and 5, which is sheets of cells, necrosis, poorly differentiated, right? And how Gleason works is that you take the most common score and then you add on the second most common as well. So let's say you have Gleason's 3 is your most common, but you have a spot of 4, it will be Gleason's 3 plus 4, a total of 7. Or if you have 5, which is a little area of 3, it would be 5 plus 3 or vice versa. And the higher the score, the more aggressive the disease. Now, this diagram just shows the compared to the ISAP grading as well, which does help pick it up. So Gleason's got 6, which could only be a 3 plus 3, would be an ISAP grade group 1, which is low-risk disease. They're generally very slow-growing, less aggressive. With these patients, you may just consider doing active surveillance. Gleason's 3+4, which is a 7, is a little bit more aggressive. They're still slow growing. This is actually called favorable intermediate risk. Then you have Gleason's 4+3, which is also 7, which is why the ISAP grade group is very important. So 7 is broken into 2. So 4+3, which is also 7, is now intermediate unfavorable, which is more moderately aggressive, fast growing. And then you have Gleason's 8, 9, and 10, which are high risk and very aggressive, rapid growing adenocarcinoma. So just as I mentioned before as well, this just breaks down the treatment a little bit better. So grade group 1, you generally just do active surveillance, which is when you follow up with these patients. You will repeat in the PSA every year, and you may repeat prostate biopsy if it's significantly going up. Then for grade groups 2 and 3, you want to do more definitive therapy where you may either do radical prostatectomy and external beam radiotherapy, or most likely is radical prostatectomy or the external beam radiotherapy plus or minus a short term of androgen deprivation, which is medical castration. However, with high risk prostate cancer or grade groups 4 and 5, the treatment is almost always medical or surgical castration. And this is just a table which also goes through the same thing. It just makes it a lot easier to break down based off the PSC as well, and to break down the risk. So as I mentioned before, you have your active surveillance. This would be for low-risk prostate cancer. You have your radical prostatectomy and external beam radiotherapy, which is for intermediate. And then you have your androgen deprivation therapy, which will be for high-risk prostate cancer. And then, of course, because so many patients or some patients do present with metastatic symptoms, you would also have options for radiation to spine or even a metastatectomy and steroid to help with the symptoms. Now, this is just an NCCN flowchart. You could go through again afterwards if you want, just showing risk as well as treatment for these patients. And it's just a little bit more in depth. All right. So we're going into renal carcinoma now. Just a summary. I know we did some anatomy with Dr. Tam already, so just going to skim over it. I'm going to be very brief. So the kidney itself is broken up into cortex, medulla. Then you have your renal pelvis going down into your ureter, right? And then you will remember that historically your nephron, the convoluted tubules are most commonly in the cortex, right? And that is why you generally get renal cell carcinomas presenting more in the cortex, because they are generally from the convoluted tubules, whether it's the proximal or distal. So renal cell carcinomas are the most common primary malignancy of the kidney. It usually presents in the age group of 60 to 70 years old. It is a male to female ratio of 2:1, and the most important risk factor for such is smoking. We could also have risk factors of hypertension, heavy metals such as cadmium, and then you could have patients who have acquired polycystic kidney disease or on hemodialysis. They are at increased risk of renal cell carcinoma as well. Clinical manifestations usually is hematuria, which is actually most commonly microscopic hematuria. You could have flank pain. However, flank pain usually presents with larger masses, and well, palpable masses are larger masses as well. You have your polycythemia, which could present in 5 to 10% of patients, and that is because the renal cell carcinomas do produce erythropoietin, which could give you elevated, red blood cell production and giving you polycythemia. One of the paraneoplastic symptoms as well is hypercalcemia, and you would sometimes get symptoms of such as your moans, groans, psychiatric overtones. And then, of course, the most common finding now for these renal cell carcinomas are actually incidentally found when you go to A&E with appendicitis and they find carcinoma, or you go with gastritis and they find renal mass on incidentally as well. Um, Say different investigations that are done would be a urine microscopy because they do present generally with microscopic hematuria. You also do a urine analysis. You will start generally with a KUB ultrasound, then you want to do a CT abdomen with IV contrast, and you could do a renal biopsy. General management would be a partial nephrectomy. You could also do a radical nephrectomy, which is the most common management. However, with partial nephrectomies, you do have some renal sparing, and this is generally for smaller masses, usually in the pools to anything less than 3 to 4 centimeters. And of course, you could do chemotherapy as well. The prognosis for renal cell carcinoma is 70 to 90% at the 5 year if there's no distant mets involved. However, it drops to 60% when you have renal vein or perinephric fat involvement as well. There are some hereditary disorders involved, such as your von Hippel-Lindau syndrome. You have it associated as well with hereditary leiomyomatosis, hereditary papillary carcinomas, as well as great dog-Dubé syndrome. And with the VHL, what most commonly happens is that it affects the hypoxia-induced factor, which then increases the VEGF, which then feeds the tumors, which makes them grow larger as well as become more vascular. The most common type of renal cell carcinoma is the clear cell carcinoma, and this is in 70 to 80% of patients. They are mostly sporadic. However, the sporadic ones do follow up with chromosome 3 mutations and VHL disease as well, and they generally arise from the proximal convoluted tubule. Firstly, there are large solitary lesions in the pool, yellow, orange, or gray to white. They have cystic softening or hemorrhage. They're on histology or microscopically, they are clear cells, which is where they get their names, with small round nuclei. They commonly invade the renal vein and may actually invade all the way up to the heart, actually. They often fungate into the collecting system as well, or the renal pelvis. Then the second most common type of renal cell carcinoma, at 10 to 15%, is the papillary cell carcinoma. Now, they are also sporadic and familial. These ones are associated with a chromosome 7 mutation on the MET, and these ones arise from the distal convoluted tubule, unlike the proximal in the clear cell carcinoma. They are often bilateral, multiple, so you may have them, multiple of them in the same kidney. They're usually in the pools. They have necrosis and hemorrhage, usually orange-yellow masses. And on histology, they have your clear pink cytoplasm and may have samoma bodies on histology. And then you have your chromophobe carcinoma. These account for 5% of renal cell carcinomas. Now, these ones arise from the inculcated cells of the collecting ducts. These ones have a good prognosis. Firstly, they are tan brown mass. However, on histology, they are clear flocculent cytoplasm, very prominent cell membranes with pale eosinophilic cytoplasm and a halo around the nucleus. Now, I just have the same NCCN guideline that helps just to summarize what we do when we find a suspicious mass. You go back to your history and physical examination. You want to do a CBC, urinalysis, abdomen, CT, MRI, CT or MRI of the abdomen and pelvis. You want to do a CT chest to check for mass as well. Sometimes you want to do a bone scan or brain MRI if you think they have mets. And then if it's stage 1, you may go with a partial nephrectomy. However, if it's stage 2 and above, you'd want to go with a radical nephrectomy. Yeah, and then this goes in similar as well. So with your partial nephrectomy or your radical nephrectomy, then you want to continue with surveillance, adjuvant chemotherapy, etc. And it just continues with stage 5. Usually, there may be surgically resectable, then you would consider radical, but most times it is unresectable, where you just do your tissue sampling and then go on with chemotherapy. Now, of note, we're going to cover this a little bit more in depth just now. You have urothelial carcinomas as well. And urothelial carcinomas can also involve the renal pelvis. They are 5 to 10% of primary renal tumors actually do arise from the urothelium of the pelvis. They're usually discovered early. Now, they're discovered early because the renal pelvis is small. So you only need a small mass to cause hydronephrosis, to cause hematuria. They are associated with Lynch syndrome, which is similar to prostate cancer. And they usually infiltrate early and have a very poor prognosis because of that. Yeah. Now, continuing with urothelial carcinomas, the next one where they're most common actually is in the bladder. So the bladder is a hollow muscular viscus. When it is fully distended, the mucosa is generally flat. However, when it is empty, the mucosa becomes folded. It is partially retroperitoneal, sitting behind the pubic bone, as when it becomes fully distended, the dome of the bladder actually extends above. The trigone is at the base, where you have the entrance of the urethral opening as well as the two ureters. Microscopically, you have four main layers, where you have a urothelium, where most of the carcinomas come from, which has three other layers, which would be the basal, apical, and sorry, this in my notes. There, and then you have your lamina propria, you have your muscularis propria, or your detrusor muscle, which has three main layers as well. Your longitudinal on inner and outer, and then a circular layer in the middle. And this is usually more prominent in the trigone, and it's more disorganized as you go throughout the rest of the bladder. And then you have your serosa adventitia as well. So bladder carcinoma accounts for 7% of all carcinomas. It is 95% of it is of epithelial origin, and majority of those epithelial origin carcinomas is the urothelial carcinoma, and then the rest would be squamous cell carcinoma. So urothelial carcinomas are usually multifocal. They can present anywhere there's urothelium, which is the bladder, ureter, and renal pelvis, as I mentioned before. They generally have two main precursors, which are the non-invasive papillary tumors, and then your flat non-invasive urothelial carcinoma as well. However, in the majority of times, you have found bladder mass, they would have already had some form of invasion, and you may not see these precursors, as most of them present as invasive tumors. Now, there is a male to female ratio of 3 to 1. There is in the ages of 50 to 80 years. It's usually non-familial, and the most important or the highest risk factor is of smoking. It can be up to 7 times, depending on how long they've been smoking. You also have occupational exposures such as aerial amines, you have aluminum exposure, you have different aromatic compounds that could also increase the risk of urothelial tumors. Now, you also have schistosoma hematobium. These ones are actually more common to form squamous cell tumors, though. What it is the ova is deposited into the bladder mucosa, which causes chronic irritation and chronic inflammation, which then causes dysplasia, metaplasia, and sometimes neoplasia, forming the squamous cell carcinoma. You could also have urothelial tumors with long-term analgesic use, irradiation if you've had previous pelvic radiation, such as if you've had genitourinary. So if you've had any gynecological malignancy where you had to do brachytherapy or external beam radiotherapy, or with prostate cancer, sometimes you may have radiation related bladder cancer years down the line after radiation for prostate cancer. You also have increased risk in long-term cyclophosphamide use. And generally, just like with the schistosoma hematobium, you have any chronic irritation in the bladder could cause a squamous cell carcinoma, which would, so in patients who have neurogenic bladders where you may have put in a suprapubic catheter or a long-term indwelling catheter of any type really, that chronic inflammation or irritation could cause carcinoma in the area as well. Of note, in case you're wondering, the schistosoma is most common in Egypt and Sudan. You do have some genetic mutations that are involved. You have your TERT, you have your FGFR3, as well as your TP53 and RB tumor suppressor genes and HRAS. Clinically, they present with painless hematuria. Most often, again, in the release, it would be microscopic or discovered urinalysis. However, it could be gross hematuria as well, depending on how large the mass has become. Depending on how large the mass is, as well as where it is located, you could have some lower urinary tract symptoms, such as frequency, urgency, and dysuria. You may have recurrent UTI and pyelonephritis if it causes urinary obstruction, such as like if it is near the ureter orifices or if it is in the ureter or renal pelvis. And yeah. So investigations would have your urinalysis. The main one that you would do is a cystoscopy, which could be done in the office. You could do CT-IVU as well, because you would want to follow up the ureter and renal pelvis to see if there are any masses up there as well. And then, of course, there is the transurethral resection of bladder tumor, which could actually go the same time as the cystoscopy. You could actually do it similar to like a TURP almost, where you resect, if it's a small tumor, you can resect all of it, or you could take some for diagnosis, for histological diagnosis. Now, it's staged differently. So you have stage 0, which is your carcinoma in situ. This one has not invaded the lamina propria at all. You have your stage 1, which then the carcinoma begins to involve the, one second, sorry, begins to involve the lamina propria, and then you have your, sorry, this one involves the muscle layer. Give me 1 second. I'm just going to have to pause for 1 minute. Okay. Okay, back. Yes, so then you have your stage 3A, which has invasion through the muscle into fat, and you may have it in a very close regional lymph node, or 3B, which then involves further lymph nodes from the bladder. And then you have your stage 4, which then starts involving further lymph nodes, as well as distant mets to the lung and liver. So management. There are different ways to manage bladder tumors. So first line, if it's small lesion, you would do your TURBT, which is your transurethral resection of bladder tumor, and then you have intravesicular installation of BCG. And what this does is that it causes reaction, an inflammatory reaction in the bladder, which then could destroy the seeds of tumor that you may have. Now you have partial cystectomy as well. This one is very rare because why you instill the BCG is to remove any other seeds of tumor you have there. However, If you remove just an area, you may have recurrence in a different area inside the bladder. So this is very rare. You could have your radical cystectomy and urinary diversion. Now, this one is more reserved for larger T1 lesions, which could be up to 4 centimeters. You may consider it. Or if you have any T2 or T3 lesions, you would want to consider radical cystectomy and urinary diversion. Now, radical cystectomy involves removal of the bladder, regional lymph nodes. You may also remove part of the uterus, top of the vaginal vault as well, right? And then, of course, if it is a stage 4, the option is really just chemotherapy. And then you could also do radiation in T to 4, T2 to T4. However, it's not commonly used as it's not as effective as chemotherapy. I did forget to mention for the radical cystectomy, you may consider urinary diversion. You will do a urinary diversion as well. You could do something like an ileal conduit, where you take a piece of the ileum and bring that out to the abdominal wall like a stoma and attach the ureters to it. Or you could do something as simple as nephrostomies. Prognosis. Now, this is related to the depth of invasion into the bladder wall. It's associated with the pathological grade of the tumor, presence versus absence of carcinoma in situ, the number of tumors, the size of the tumors, invasion in the lamina propria, and whether the tumor is a primary tumor or a recurrence. And as I mentioned before, recurrence is very common. It can recur anywhere in the bladder or where there's urothelial tissue, may go up the ureters and into the renal pelvis. So because of the recurrence, you always want to make sure that you're doing regular screening afterwards, where you do cystoscopies. So papilloma is the one form of urothelial tumors. It's usually found in younger patients. They are 0.5 to 2 centimeters. They're superficially attached to the mucosa. They're histologically identical to the normal urothelium. They have a thicker base than a normal so histologically identical to the bladder epithelium, urothelium. Then you have your papillary urothelial neoplasm of low malignant potential. Now, these ones have a thicker urothelium than the papilloma. They're a little bit larger. They have a very low risk of malignant potential. Then you have your low-grade papillary urothelial carcinomas, which have orderly architecture, as seen in the top image, mild atypia, and they very rarely invade in up to less than 10% of patients. High-grade papillary urothelial carcinoma are usually disorderly architecture, high risk of invasion, in up to 80% of instances. And then we have going into our squamous cell carcinoma now. These are a lot more rare. Is associated in 3 to 7% of bladder cancers. And all pure squamous cell carcinomas are caused by chronic bladder irritation, whether it is a parasite, whether it's indoor catheter, or other form of irritation. However, they're often mixed with urothelial carcinoma as well. And again, I just have this flow chart which helps go through diagnosis, treatments you'd want to do, as well as treatment for urothelial carcinomas. And that is it. Thank you very much. Some of my references. Any questions?